Hello, Bali YouTube channel.
We are looking at a pretty staggering reality today.
Yeah, it's a huge one.
Because, nearly 10% of adults in the United States are currently struggling with a condition that is actually the leading cause of disability worldwide.
Worldwide.
Yeah, right. I'm talking about clinical depression. And, chances are if you, the listener, aren't personally navigating this right now, you absolutely know and love someone who is.
Almost certainly. It's incredibly common.
Exactly. So our mission today, and we're using a deeply insightful clinical overview from TED-Ed for this, is to figure out how we can use a true scientific understanding of this disease to provide effective support and treatment.
Right.
Think of this deep dive as, an essential addition to your life toolkit.
It is a vital tool, for sure.
Yeah.
And, we are dealing with a heavy topic, undeniably, but the science here provides a really clear, highly effective avenue for hope and for action. Like, this isn't some unsolvable mystery.
Right, but usually when we talk about a medical diagnosis, there's this expectation of precision, I guess, like engineering. You break your arm, the x-ray shows a jagged white line, and the doctor just points and says, yep, there it is, broken.
Right. It's very objective.
Exactly. It's visible, it's neatly categorized, and that is comforting. But when you step into the world of mental health, it feels like that x-ray machine is just broken. We're looking at a diagnostic landscape that is, well, incredibly murky.
Oh, it is the absolute definition of diagnostic muddy waters.
Yeah.
And, to support someone effectively, we have to clear away those societal misunderstandings first.
Yeah.
Because that murkiness has massive real-world consequences for how patients are treated by their families, their employers, or, even themselves.
So let's unpack the biggest hurdle right out of the gate, which I think is a semantic one.
Okay.
The word depressed is just so heavily misused in our everyday language, and I think it creates this massive barrier to actually understanding the clinical reality.
I totally agree. We've completely diluted the word.
Yeah.
Because almost everyone feels down from time to time.
Sure.
You get a bad grade on a test, or you lose a job, you have a bad argument with your partner. Even just a string of gloomy, rainy days can bring on feelings of sadness.
Yeah, the winter blues.
Exactly.
Yeah.
And sometimes there isn't even a trigger at all. A low mood just pops up out of the blue.
But then the sun comes out, or you make up with your partner, or you finally get a new job, and that feeling lifts. Like the circumstances change and the sadness disappears.
Precisely. That is situational sadness. Clinical depression is fundamentally different.
Right.
It is a medical disorder.
Right.
And it will not go away just because you want it to, or just because your circumstances improved.
It sticks around.
It lingers.
Yeah.
To meet the clinical threshold, these symptoms must be present for at least 2 consecutive weeks.
2 weeks.
And crucially, they have to significantly interfere with a person's ability to work, to play, or to love.
Yeah. That distinction is so important. It really reminds me of how we use the word starving.
Oh, that's a good analogy.
Yeah, you miss lunch, it's like 3 in the afternoon, and you say, oh my gosh, I'm absolutely starving.
Right, but you aren't.
No, you're just hungry.
Right.
Actual starvation is a severe systemic biological failure. And using feeling depressed to describe a bad day at work versus having actual clinical depression is the exact same linguistic trap.
It completely minimizes the actual medical emergency.
Exactly.
Because when we look at the actual psychiatric guidelines, it's not just about feeling sad. A person needs to exhibit at least 5 specific symptoms to qualify for diagnosis.
5. Okay, what are they?
Well, we're talking about a pervasively low mood, obviously, but also a profound loss of interest in things they normally enjoy. That's a condition called anhedonia.
Anhedonia.
Right. Then there are changes in appetite and overwhelming feelings of worthlessness or just excessive guilt.
And it completely deregulates your sleep, right? Like you end up sleeping way too much or just barely sleeping at all.
Yes. Poor concentration is another major one. And then there are physical manifestations, like psychomotor agitation.
Which is what, exactly?
It's a severe restlessness. Or, on the flip side, a profound physical slowness and a complete loss of energy, like you're moving through molasses.
Wow.
And, of course, recurrent thoughts of suicide. So you need 5 of those, persisting for 2 weeks, disrupting your daily life. That is the clinical reality.
But, because we can't see that list of symptoms on a simple blood test, people treat depression like it's an invisible illness. Like it's just a mood you can't snap out of, or worse, some sort of character flaw.
Which is incredibly damaging.
So let's look at what's actually happening in the body. If you could put on a pair of X-ray glasses and look into the brain of someone with severe clinical depression, what would you physically see?
You would literally see structural changes.
Really?
Yeah. With the naked eye on a brain scan,
Yeah.
you can observe smaller frontal lobes. You can also see significantly smaller hippocampal volumes. The hippocampus is vital for memory consolidation and emotion regulation, and in depressed brains, it physically shrinks. The brain's architecture is quite literally altered.
Okay, I want to pause on that because we really need to think about what a shrunken hippocampus actually looks like in someone's living room.
Right, the practical application.
Yeah, because when your spouse completely forgets a conversation you had yesterday, or they just can't seem to regulate their frustration over something as minor as a spilled glass of water,
Mm-hmm.
that is not them being difficult or, intentionally tuning you out. That is a compromised hippocampus physically struggling to perform its basic biological functions.
Exactly. It manifests in behavior, but the root is completely structural. And on a more micro scale, the brain's communication system breaks down too.
How so?
We see abnormal transmission or outright depletion of essential neurotransmitters, specifically serotonin, norepinephrine, and dopamine.
Could you break those down for us? Like, what exactly is going offline when those three chemicals are depleted?
Sure. Serotonin is largely responsible for mood stabilization and just a general sense of well-being.
Okay.
Norepinephrine regulates alertness, energy, and your body's fight-or-flight response.
Got it.
And dopamine is the reward center. It dictates motivation and pleasure. So when dopamine drops, that's where the anhedonia comes from.
Oh, that makes so much sense.
Right. That's why your favorite hobby suddenly feels like an exhausting chore. Your brain is quite literally no longer producing the chemical reward for doing it.
So we have a structural issue with the shrinking brain regions and a chemical issue with the neurotransmitters. But the sources also pointed out that this goes way beyond the brain. Like, it's a systemic failure.
It affects the entire body. Depression blunts your circadian rhythms.
Your sleep cycles.
Yeah. It causes specific measurable changes in the REM and slow wave parts of your sleep cycle, which means your brain never gets to truly clean itself or rest.
That sounds exhausting.
It is. And it even causes endocrine and hormone abnormalities. You see persistently high levels of cortisol.
The stress hormone.
Exactly. And the deregulation of thyroid hormones.
Okay, I have to push back against the whole invisible illness stigma again here.
Please do.
Because if you can literally see a shrunken hippocampus on an MRI, and you can measure deregulated thyroid hormones and spiked cortisol in the blood, telling someone with depression to, just get over it or cheer up, it's absurd.
Completely absurd.
It is exactly as absurd as looking at that broken arm on an X-ray and telling the person to just will their bone back together using positive thoughts.
Right. It is biologically impossible to just get over a deregulated endocrine system.
Yeah.
But this does raise a really common question. If this is a physical, biological reality, why do some people get it while others who go through the exact same hardships don't?
Well, the sources mention a complex interaction between genes and the environment. How does that actually work?
This is the field of epigenetics. So think of your DNA as a massive control panel with thousands of switches.
Okay, switches.
Some people inherit genes that predispose them to depression. But having the gene doesn't mean you automatically get the disease.
Interesting. So it's just sitting there.
Right. It takes an environmental factor like chronic stress, a traumatic event, or even a severe physical illness to act as the finger that flips that genetic switch to on.
Ah.
And once flipped, the body starts altering how it handles stress hormones, which leads to the structural and chemical cascades we just talked about.
So you might have the blueprint for the illness, but the environment actually builds the house.
That's a fantastic way to look at it. And because this biological cascade manifests as intangible emotional and behavioral symptoms, it's incredibly hard to know who is struggling.
Yeah, because it's hidden.
Someone can look perfectly fine, be highly functioning at work, and internally be dealing with severe dopamine depletion and cortisol toxicity.
But, knowing these physical changes are happening internally makes this next reality really hard to digest. Because if this is a systemic breakdown of the brain's hardware, why aren't people rushing to the doctor the way they would for, say, a heart attack?
Yeah, the delay in treatment.
Right. The National Institute of Mental Health data shows it takes the average person suffering from a mental illness over 10 years to ask for help, a decade of silent struggle.
It's a heartbreaking statistic.
10 years.
I know. And a large part of that delay is because we don't have a simple, universal diagnostic swab. We can run at an annual physical to predict where or when depression will show up.
See, I think it's more insidious than just lacking a diagnostic swab.
How so?
If we look back at the symptoms we just listed, loss of energy, feeling worthless, poor concentration, profound guilt, it seems to me that the very symptoms of this disease are exactly the things that make seeking treatment feel completely impossible.
It's a cruel irony, isn't it?
Yeah.
The disease actively neutralizes the exact executive functions required to fight it. To get help, you need the energy to research doctors, the self-worth to believe you actually deserve to feel better, and the concentration to navigate the complexities of modern healthcare.
Which is hard enough on a good day.
Right. And depression robs you of all three simultaneously.
It's like a computer virus that is specifically programmed to disable your antivirus software before it does anything else.
Yes, that's exactly it. And that is why that 10-year gap exists. But when people finally do bridge that gap, when they finally get into the system, the treatment arsenal we have today is highly effective.
Let's talk about that arsenal, because I think a lot of people have major misconceptions about treatment.
Definitely.
When I hear medications for depression, the immediate fear I hear from people is that they'll become numb or, turn into a zombie. But based on these sources, the goal of these drugs isn't to sedate you, right? It's about fixing a biological leak.
Exactly. The most common medications are SSRIs, which stands for selective serotonin reuptake inhibitors. They don't flood your brain with artificial chemicals to numb you. Normally, your brain releases serotonin into the synaptic cleft.
That's the gap between neurons, right?
Right, the gap. It releases it to send a message, and then it quickly absorbs it back up. In a depressed brain, that absorption happens way too fast before the message can even be received.
Oh, I see.
So an SSRI simply blocks that reuptake process. It leaves your natural serotonin in the gap just a little bit longer so the neighboring neuron can actually catch the signal.
So it's literally just helping your brain use its own natural resources more efficiently.
Precisely.
Okay.
And medication is usually paired with therapy, which complements it beautifully. Because while medication improves the chemical signaling, therapy actually changes the physical structure of the brain.
Wait. Talking to a therapist physically changes the brain's architecture. How does that work?
It's a concept called neuroplasticity. The brain is malleable. When you engage in therapies, like cognitive behavioral therapy, you are actively identifying and challenging distorted thought patterns. Every time you consciously redirect a negative thought, you are firing new neural pathways.
Wow.
Over time, like a muscle, those new pathways get stronger, and the old destructive pathways physically wither away. Therapy effectively strengthens the prefrontal cortex's ability to quiet the fear response in the amygdala.
That's incredible. It's quite literally doing physical reps at the brain gym.
That's exactly what it is.
But what about the extreme cases? For people where standard SSRIs and therapy just aren't moving the needle, the sources mentioned a few advanced treatments that sound, honestly, pretty intimidating at first glance.
Well, for treatment-resistant depression, we have very powerful tools. One is electroconvulsive therapy, or ECT.
Right.
Now, popular culture has heavily stigmatized ECT, portraying it as some horrific punishment. But in modern clinical practice, it is essentially a highly controlled seizure induced in a specific part of the brain while the patient is under general anesthesia.
I mean, inducing a seizure sounds radical. Why does that work?
Because a seizure causes a massive immediate release of a protein called brain-derived neurotrophic factor, or BDNF.
BDNF, okay.
Think of BDNF as high-powered fertilizer for the brain. It rapidly stimulates neurogenesis, the growth of new brain cells, and helps regrow those shriveled connections in the hippocampus.
Oh, wow.
It functions almost like a hard reset for the brain's electrical and chemical systems, and it is incredibly helpful for severe cases.
A chemical hard reset. That makes a lot of sense when you explain the mechanism behind it. And the sources also mention transcranial magnetic stimulation.
Yes, TMS. It uses targeted magnetic fields to stimulate nerve cells in the underactive areas of the brain, like those shrunken frontal lobes we mentioned earlier.
Right.
It's completely non-invasive. You literally just sit in a chair while a magnetic coil is placed against your head. And it really represents just how far our physical understanding of this disease's geography has come.
So we know this is a highly treatable physical illness.
Very treatable.
But we also know that the first steps toward that treatment can feel like climbing Mount Everest for the sufferer. Which brings us to the most important part of this deep dive. How can you, the listener, step in? How do you help bridge that 10-year gap for a loved one?
The key is shifting from passive well wishes to active task assistance.
Active task assistance.
Yes. When someone is drowning in a lack of energy and poor concentration, simply saying, hey, let me know if you need anything, is almost entirely useless.
Yeah.
They do not have the executive capacity to figure out what they need, let alone ask for it.
You essentially have to become their temporary executive function.
Precisely.
You don't ask them to research doctors. You offer to sit down with your laptop and look up local therapists for them. You offer to make the phone calls to check if those therapists actually take their insurance. You sit at the kitchen table and write out a list of questions they can take to their primary care doctor. You shrink the insurmountable mountain into single, manageable steps.
And alongside that practical help, you have to actively tackle the guilt and shame they are feeling.
Which is huge.
Remind them explicitly that this is a systemic medical condition compared to asthma or diabetes. Remind them it is a biological reality, not a personality trait, and certainly not a weakness.
I want to highlight something critical here about what not to do.
Oh, this is so important.
Because when a friend is hurting, our natural human instinct is to try and connect through shared experience. It's what I call the empathy trap.
Yes.
Your friend says they can't get out of bed, and you instinctively say, oh man, I completely understand. I felt the exact same way when I lost my job last year, but, you'll bounce back.
And in this specific clinical context, that well-intentioned instinct is actively harmful.
Because it completely invalidates the clinical reality we just spent this whole time talking about. Comparing their biological depression, their shrunken hippocampus, and depleted dopamine to a time you experienced normal situational sadness doesn't make them feel understood.
Not at all.
It makes them feel deeply guilty. They look at you and think, well, they felt this way and they bounce back. Why can't I? I must be weak.
Right.
It reinforces the exact feelings of worthlessness the disease thrives on.
This is a vital point. Do not compare their illness to your temporary emotional states. You wouldn't tell someone having an asthma attack, hey, I totally get it. I was really out of breath after running yesterday too. It's fundamentally different.
So if we avoid the empathy trap, what is the best way to communicate?
You utilize the power of blunt honesty. Open conversations erode the stigma. And there is one area in particular where blunt honesty is scientifically proven to save lives.
Which is?
Asking about suicidal thoughts.
Oh, man. People are terrified to do that. There's this pervasive myth that if you ask someone if they are thinking about suicide, you are somehow planting the idea in their head.
It is entirely false. Research consistently shows that openly asking someone about suicidal thoughts actually reduces their suicide risk.
Really? Reduces it?
Yes. When you ask the question directly, are you planting an idea? You are opening a pressure release valve.
Wow.
You are telling them, I see how much pain you are in, and I'm not afraid to sit with you in the darkest part of it. It removes the taboo and replaces it with a safe space.
That is incredibly powerful. Just the act of asking the question can be a lifeline.
And all of this support leads to a positive feedback loop of healing. The more you, the listener, step up to provide that active task assistance, the more patients will successfully enter the medical system. When they enter the system, they get the treatment they desperately need. But they also give the scientific community more data.
Right.
Every patient treated helps researchers learn more about those complex epigenetic interactions and micro changes in the brain. And that data directly accelerates the development of even faster, more targeted treatments.
So by helping one person, you are actively contributing to the acceleration of the science itself. Before we wrap up, I've been thinking about this feedback loop and about those highly measurable systemic physical markers we discussed earlier.
Like the blunted circadian rhythms and the spiked cortisol.
Right, the physiological footprint of the disease. Well, it makes me wonder about the future of that 10-year treatment gap. Right now, most of us are walking around wearing smartwatches or fitness rings.
Oh, sure.
And they are constantly tracking our sleep stages, our heart rate variability, our body temperature. What if, in the very near future, the everyday wearable technology we already use could be developed into that missing diagnostic swab the experts say we lack?
Oh, that's fascinating. You're suggesting that the hardware to catch this early is already sitting on our wrists.
Think about it. What if your smartwatch could detect the physical onset of clinical depression? The shrinking slow-wave sleep, the subtle shifts in your circadian rhythm weeks, or even months before the intangible emotional symptoms register in your conscious mind.
Before you even feel sad.
Exactly. If the physical biology changes first Algorithms might be able to flag it. We could effectively eliminate that 10-year gap entirely, catching the disease before it has a chance to disable the patient's executive function.
It is a thrilling possibility. It takes depression entirely out of the realm of the invisible and turns it into a preemptively measurable data point. It reinforces everything we've discussed today. This is biology, not a flaw in character.
So to bring it all the way back to where we started, the diagnostic X-ray machine for mental health might feel a bit broken right now. But the science is incredibly clear about what depression is, how it physically alters the brain and body, and how highly treatable it is.
Extremely clear.
You don't need an X-ray to validate someone's pain, and you don't need a medical degree to help them take that first impossible step toward healing. You just need to show up, offer to be their executive function for a little while, and be willing to have the hard conversations. Take this knowledge, add it to your toolkit, and look out for each other. We'll catch you on the next deep dive.